Dr. Tiffany Osborn currently serves on the Centers for Disease Control and Prevention's National Sepsis Task Force. She additionally serves on the National Quality Measures Technical Expert Panel for the ACEPS Clinical Emergency Data Registry. She is a representative to the Surviving Sepsis campaign. She worked on the National Quality Forum's Infectious Disease Committee. And a few days ago, Dr. Osborn was on CNN with Pamela Brown. Dr. Osborn, you are welcome to Morbidity and Mortality podcast.
Well, thank you so much for having me. It's an honor to be here with you today.
It's my huge honor and privilege to have you. I saw your interview on CNN with Pamela Brown, and I was awestruck because of the huge sacrifice you've made. I know you've been making huge sacrifices in your entire career, but this one touched me. Please, Dr. Osborn, you took an extraordinary decision at the start of COVID-19 pandemic. I just want you to share with us this decision that you took.
Sure. So first, let me just say that, I'm very happy and I feel very blessed and appreciative to be back in my home with my family full time. But I just need to recognize that there are a lot of people that weren't able to make it home to their families, including almost 4,000 U.S. healthcare workers. And so I just want to say that I'm thinking about those families, and I just want them to know that they are in, my family's thoughts and prayers. So what happened was in March, we were, the pandemic had come to the United States. We were seeing how things were building up in New York. We'd already seen what had happened in Italy, and there were a lot of questions and not a lot of data. So it was unclear how contagious it was. It was unclear at that point all the potential routes of transmission. And so my husband and I discussed what were we going to do, because we talked about like the previous SARS epidemic where it had been transmitted through ventilation shafts, and we were thinking, what are we going to do? Because I work both in the emergency department and in the intensive care unit. I'd helped to set up the COVID ICU at our hospital. I helped with guidance. I knew I was going to be working with that population in both areas. How do I take care of the community and our patients, but at the same time, don't do it at the risk of my family? And that's the question that every healthcare worker was asking. And no matter where you are, that's the question everybody was asking. So I'm no different from every other healthcare worker. What was a little different is that we had already been saving for an extension to our house. And we took that money that we'd been saving, and it ended up being a RV in the driveway.
Wow, what a sacrifice, Dr. Osborn. You took the money you've been saving and you invested it in an RV. Just that is huge. And you lived in the RV for 1 year?
So a couple of things. So one, the first 6 weeks I was exclusively in the RV. And then I realized that I thought I was going to lose my mind. I mean, it was just, it was very difficult, as it has been difficult for people across the country who have been in isolating situations. So at that point, what we decided is I worked with my supervisors in both critical care and emergency medicine. And I just bundled all of that time together and tried to work all the shifts as much as I could together, straight one after the other. And then I would wait a few days, take a test, and then I'd spend whatever was left of the month in the house with the family. So after that first 6 weeks, it's not like I was in there all the time. I probably got, maybe a week or so in the house per month, which was helpful. But what I do have to put forward is, I mean, think for a second. I mean, I happened to be in a position where I had the resources to do that. And a lot of people did not have the time because it sort of came up all of a sudden. We had the benefit of seeing that this was coming. We had the benefit of, having saved for something else, so we had the resource available to redirect it. And a lot of frontline providers did not have those resources, and they had that exceptional additional stress of the concern about how they protect their family and still continue to do their job. And I just want to recognize those people, the other people within my medical community, my medical family, for the sacrifices that they made that were, more significant than myself.
Wow, thank you for being so humble with what your sacrifice you've made. How did your husband take your decision, and how did your husband and children, how did they cope?
So, my son had this idea of, hey, Mom, why don't you live in the garage? And I'm like, and there have been colleagues who did live in their garage, but there's no heating or air conditioning in my garage, and there's no bathroom in my garage. And I'm looking at my son and I'm thinking, do you know me? I mean, like, I'm not going to be in the garage. But it was just an example of how, they were trying to provide, contribute to the conversation. And, but, again, it was just, there was so much uncertainty. So, those were the decisions that we made. And my husband had been in the military in the past, so he's an analyst, so he's very data driven. So when I was weak, he was strong. He's like, we have a checklist. We're going to go through the checklist. And I'm like, I just want to be inside with my family. He's like, we have a checklist. We're going to go through the checklist. So we really, we helped each other. So, and the family just kind of all came together, and everything that my daughter said was true. I mean, she really did step up to fulfill a lot of the roles I would normally do. And my husband stepped up and my son stepped up. There were definitely challenges. But at the end of the day, we came together as a family. And at the end of the day, we were able to come back together as a family. So those are, two things that we feel very appreciative and blessed about.
Well, I'm glad you got that support from your family. And I just want to thank your husband and your daughter and your son for stepping up to the plate when you were, busy helping and saving lives. Thank you, thank you, thank you so much. So, Dr. Osborn, the vaccine is out. And I know you got it, the vaccine. And when you got it, you said that it was a historic day for you. Why historic?
Well, it felt historic for a number of reasons. One was because it came so much faster than anybody could have anticipated. There were a lot of resources that were put into making a safe, effective, tested vaccine. And, the ability not only that it was manufactured, tested, but also rolled out in a way in which we had access to it was, in my mind, was historic. I guess the other historic part to me in my mind was just the fact that I was looking at being able to get out of that camper. So, and I don't want to, I mean, look, the camper was fantastic. It was great. And if you had to do this, doing it in an area that was more comfortable and being so close to my family, a lot of people didn't have that option. I know people who had to send their children away. I knew people who, rented out an extra apartment with some other healthcare workers, so they weren't right next to their family. So there were a lot of blessings that I'm appreciative for. Having said that, because of everything the camper represented, I was very happy to see it go.
Great, 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 great. Thank you so much for providing that answer, Dr. Osborn. So tell us some more about these vaccines. You know, for instance, the how important it is for people to understand that the mRNA vaccines have been there for decades. Same thing goes for the inactive viral vector vaccine.
Sure. So some of the questions that people have had is, am I going to get COVID from the vaccine? And the answer to that is no. There's also a myth that you can get the flu from the flu vaccine, and that is inaccurate as well, as you are, as you're bringing up. So the only reason to not take this vaccine is that you have an allergy to some component of it, or it's not your time yet. Those are the only two reasons why you should be thinking about not taking this vaccine, because it is a lifesaver, and not only your life, but other people around you. And not only for this virus, but it helps by everybody getting vaccinated. We reduce the potential of more adapted strains. So we want to try to get as many people vaccinated as possible.
I don't have allergies, and I know the time is now, and that's the reason I'm going to get my vaccine this Saturday.
So congratulations.
Thank
Yay.
you.
Congratulations. That's fantastic.
Thank you.
So that's your first one?
Yes, it's going to be my first one. Yeah.
Congratulations. You must be very excited.
I am super excited, Dr. Osborn. I am.
Yeah.
Who's
the first person that you're going to go see?
I haven't thought about that.
Yeah, I understand.
Yeah, I'll think about it and get back to you.
Yeah, that sounds good.
All right.
Yeah.
So why is there so much hesitancy in getting this vaccine, and how can we encourage people to do the needful?
Yeah, that's a great question. And I would say that there's hesitancy because of how quickly it came about. There's probably also hesitancy because during, and I'm not here to be political, but during the last administration, there was discussion about changing some of the FDA processes in order to get it out faster. Those things did not happen. So the reason that it got out fast is because this was the first time that the government had coordinated with private industry in order to pool their resources and make things work faster. That was part of it. The other thing is that the mRNA vaccine, that's not new science. It's not like it was just developed for this. It was developed a long time ago. It was just, this is the first time that it was applied to this. So the science is there. The studies are there. Now, the other thing I think around vaccine hesitancy is, distrust. And I think especially in our communities of color, because they had not been treated well in the past by the medical community. They had not been treated ethically in the past with the research community. And so I do believe that there may be some hesitancy surrounding how can we trust these organizations when maybe these organizations have not been forthright with us in the past. And I think that that is a valid concern that they have. And I think the way to potentially get around some of that is having recognize, get their vaccine publicly, but then also we should vaccines to be readily available in locations that they trust, in their churches, in their community centers, in their local pharmacies. These are all potential where they go and see their pastor has gotten vaccinated. They go to the community center and the coach that has been working with their children has gotten vaccinated. And those people these are relationships that they have, and I think that they would feel more comfortable if they were able to get the vaccine in locations that they trust.
Thank you for bringing up the usage of non-state actors in the vaccination process. The reason I say that is my bishop, Bishop Israel Adajala, I attend Kingdom Connection Christian Center. Another reason I might say that is because I'm getting the vaccine the same time my bishop is getting the vaccine.
Oh, wow, you should get a picture.
Yes, I will.
You should get a photograph.
I will do that.
Make sure you do that and you post it. That would be great.
I will do that. And he has been huge in disseminating the factual information since the onset of this pandemic. You know, as you know full well, there has been so many disinformation out there. But almost every Sunday, my bishop comes out and tells his congregation and his wider audience the facts. And we also have medical professionals in our church, and they also, you know, educate us about what is going on with the pandemic. So I'm glad you brought up that point, Dr. Osborn. You know, so now
I think we have to look at unconventional ways, right? I mean,
right.
You know, Stephen Covey's got a book about the speed of trust, right? About building trust, and that's not something that happens, you know, just because I tell you you should trust me. It doesn't mean you're going to trust me. You know, there's a lot of history, there's a lot of context, and I think that really has to be taken into consideration when we're discussing something as important as this.
Thank you. Do you mind telling us about the heavy strain on clinical workforce? What can be done to alleviate these strains on the clinical workforce?
Such a good question. And so, you know, first of all, I have to tell you that healthcare providers around the world have really stepped up to do the best they can for the communities they serve. And I mean, I have personally witnessed with my respiratory therapy colleagues, with my nursing colleagues, with my physician colleagues, I have personally witnessed such strength and compassion and the humanity of care at the bedside. And they have really, around the world, they have really differentiated the difference between providing care and being caring. They don't have to be mutually exclusive, but they are two different skill sets. And that really comes from an authentic place of wanting to do the greatest good. And when you think about that, and you think about the courage, and there's a lot of, and I think respiratory therapists have really been left out. These are people who were dealing with the ventilators. These are people who were dealing with the breathing treatments. And I mean, people talk to the doctors because the doctors are working these front lines, but there are other people working these front lines too. But when you think about the courage, people, and this is not just in my hospital, this is healthcare providers, hospital workers around the world. I mean, they provided care even when they were afraid. They were afraid of getting sick. They were afraid of passing it to their families. They had their own losses. There's a security guard at my work that talks about the fact that he lost 12 family members to COVID. I had a nurse, one of the nurses that I work with, come to me, and she had 2 family members in the COVID ICU and ended up losing them both. People had their own losses, their mothers, their brothers, their family members, their close friends, their colleagues, people like them. And they still came to work, and they still did what needed to be done to serve their community. And I consider myself to be proud and humbled to walk among people who bring such value and humanity into the world. And so I think that wherever you are, the healthcare workers in your community, They have really, they've really stepped up. Now, having said that, there's a cost to it. And one of the costs is what we were just talking about. You know, the healthcare system in the United States, especially, was already on edge. It was already at a breaking point. We already had, 60 to 80% of clinicians who were reporting signs of burnout. And that was before COVID. And then you throw COVID on top of it, and everybody stepped up and did what they needed to do. But there was a lot that they went through, a lot that all of the healthcare workers have gone through. And I think we need a national discussion on the fact that our clinician workforce is not, our clinician workforce is an exhaustible national resource. So you can have all the ventilators you want. If you don't have the people to run them, they don't do any good. So it is an exhaustible resource across the nation. It's something that is important, but we have to understand that it's a resource and there's a threshold to that resource. I think organizations need to understand that this is unprecedented strain. So think about that. Think about the fact that some of these hospitals, because they stopped doing surgeries, lost money. Other hospitals closed down. Healthcare workers were laid off. And what that meant was that the healthcare workers who were left had that many more people that they had to take care of. And hospitals that were left, their catchment area has now increased. So they have that many more people to also take care of. So their workload is increasing, their hours are increasing, their pay is decreasing. They're seeing some of their colleagues who have put themselves at risk who get either furloughed or laid off. And the work strain as well as the emotional strain is pretty significant. Now you put on top of that, you see people die that shouldn't die. You see people who, my youngest person that I took care of was 15, who's on the ventilator. She survived. I had a colleague whose 16-year-old daughter was on a ventilator. She survived. But there were days when half the patients that I was taking care of didn't make it out of the hospital. And, they're looking so good at one point. And then within 24 hours, things can start to change. Not for everybody, but enough people that you can't help but take a toll on you. You get to know people, you develop a connection with people, and you're talking to their families, especially when you're in the intensive care unit. In the emergency department as well, you keep them for a longer duration of time when they're in the ICU. And you're having a conversation with someone one day saying, hey, you're the healthiest person I have in my ICU right now. And 24 hours later, you're having to put a breathing tube in them. And it was very difficult for people. On top of that, it's the amount of PPE, the amount of vigilance, that's just another form of stress. So the reason why I'm saying all of that is to try to give people a mental picture of what it's like so you can understand. It wasn't just about, I went to work and COVID was there. It's, I went to work. I'm not sure if I'm going to catch something or bring something home to my family. On top of that, we're understaffed and I've been working extra hours. And then on top of that, I have to wear this really hot and heavy stuff in order to protect myself, my family, my coworkers. And on top of that, is the person that I'm engaging with going to survive? So there's a lot of mental components to this. And then if you throw the potential financial complications on top of it, it just adds another piece of stress. And so I think organizations need to understand and confront the unprecedented strain on the healthcare workforce. And HSOs should be thinking about how they can help to alleviate that. So, for example, when we were talking before about people being concerned about going home to their families, how many, I mean, my institution, after this had started, had been going on for maybe 2, 3, 4 weeks, they opened up the university dorm rooms so that healthcare workers could stay in the dorm rooms and not incur additional financial stress staying someplace where that, you know, they were paying for, like a hotel. The other thing would be having a chief wellness officer. That person would need to be someone who is more on a executive level, not someone who's on you know, the lower rungs. It needs to have the authority to be able to make change as you need to make change. And I think that clinicians need to be empowered to be able to speak freely about what they're going through without being afraid of reprisal. And I think the last thing is, you know, we talk about clinicians accessing mental health care if they need it. So 2 things on that. One is, in some states, you have to report it in order to keep your license. So if you have to report it, or you have to put it down if you're trying to get a license, then it makes you leery of trying to get help. And I think that needs to go away. That's one thing that needs to go away. I forgot what the other thing was that I was going to say, but I think that was probably a lot right there. I just feel like this is our next pandemic. Our next pandemic is maintaining our healthcare workforce.
Wow. My thoughts and prayers goes to your colleague, the security guy that lost about 12 of his family members, and the other individual that lost 2, and so many other, you know, people who have lost loved ones to this pandemic. My heart goes out to them. You know, it is a heavy strain not only on healthcare workers but also on families, and you know, it's a tough situation. But I'm happy we are digging out of it gradually. So, Dr. Osborn, how and who can allow healthcare workers to speak freely about stressors?
That's a great question.
Yeah.
So I think one of the things is that sort of the national stigma needs to be taken off the ability for people to talk about things like depression or that they're having a difficult time processing whatever it is that they're processing. There's a lot of stigma associated with that. People are concerned about how it could impact their careers. So it would be great to have, if there were a way in which we could start something that could take some of that stigma away. Additionally, making the resources available so that people who have already gone through this and okay, yeah, we were talking about what we can do, and I think national discussion, recognition that there is going to be a mental health crisis with healthcare workers. There's also going to be financial implications that healthcare workers are going to be going through, that hospitals are going through, especially rural hospitals. And small rural hospitals may be the only source of care for people for miles and miles. And then the other issue is going to be for organizations, healthcare systems, HSOs, to understand that that their healthcare workers are not an expendable resource, that there's a threshold, and that just like anything else requires maintenance. I heard somebody say, if I had a broken leg, you wouldn't ask me to go to the doctor and then 20 minutes later be back at work. So I think there's just going to have to be a realization by hospitals, hospital systems, that there is something going on that is going to require more than what a Band-Aid can fix. And if we ignore that, we do that at our own peril, and we will lose healthcare providers. And when I say empower them to be able to speak about whatever their situation was or is, that means not being afraid that you're going to lose your job because you've accessed healthcare resources. Because as we said before, it's a requirement in some states for licensure that you report it. Or that if you need to speak up about something that you're seeing or is happening with your colleagues, that you're not worried about being fired. So I think that those are important components of that. And, we've talked a lot about healthcare workers, and I appreciate that because that is my family. I would feel remiss, though, if I didn't also bring up that there were a lot of frontliners that were not in medicine. And these are people who were also going to their work and being afraid. And I think that we just need to recognize their contribution and sacrifice as well. The people who bring your mail, the people that you get your groceries from, a number of people. And, when you think about it, although there's a lot of darkness, there's been a lot of darkness associated with COVID over this past year. There's also been a lot of sparks of light throughout the community. I mean, you had everyday people in and out of medicine who were creating good with what they had. They had skills, they used their skills. They had kindness, they had strength, they had integrity, civility, and they were willing to come together and do jobs that needed to be done for the benefit of the community. And that in my mind, is what I see America as being about. Although there's been some other conversations and distractors, that's what the America I know is about. And that's been happening not just in the United States, but all around the world. And there's a side of me that feels that if we can be intentional about living our day-to-day lives with those principles that those people have shown, then we'll be making a better world, that we're going to be bringing more light, and that we're going to be able to walk out of this darkness together.
A big shout out to the sparks of life, according to Dr. Osborn, people who have not been duly recognized during this pandemic, frontline workers, and so many of them, the grocery store attendants, the mail people, and so many of them. I remember at the thick of the pandemic, my 11-year-old daughter wrote a little banner saying, "Thank you, the mailman. Thank you, my grocery attendant." She was just she listed the names of people who have been unrecognized in this pandemic, and they've been playing huge roles, so thank you for bringing that up and calling them sparks of light.
Right. With our fire department, our EMS providers, our police, there's a lot of people who've come together to try to do good with what they have.
Yes.
And that's the best that we can all do, right?
That's right. I agree with you. And that brings out the best in us, so yeah. Dr. Osborn, can you tell us something about dexamethasone in the treatment of COVID-19 patients? Who benefited from this treatment and who did not?
So dexamethasone, the groups that benefited from dexamethasone are those that were over 7 days from the point of infection, and those who required some sort of additional support. So I want to say it wasn't a rescue therapy. It's not as beneficial once you are so sick. But as you're starting to become more sick, you're requiring oxygen therapy. You may be requiring Optiflow or BiPAP, and you've been about 7 days from the point of symptoms, initiation of symptoms. Those tend to be the people who do the best and have a mortality benefit from that.
Mm. What other treatments seem to have worked or to be working for COVID patients?
Right. One thing I want to say about
Dexamethasone?
about the dexamethasone, I'm trying to, my son just knocked on the door, and so I lost my train of thought there for a second. But um, anyway, it'll probably come back to me.
It's
But
okay.
yeah, but dexamethasone is one thing that can be of benefit. Other things that we think is of benefit is the monoclonal antibodies. There's something called TOSI that we think may be of benefit now. Convalescent plasma is something that we thought was beneficial, and a recent large randomized controlled trial showed no difference. So it's not, there was no increased harm, but it's unclear if there was increased benefit. Now there's a little bit of complication with that because of how we're testing whether or not something is high titer. So, but in general, I would say that is unclear to not beneficial. I think the majority of the things that, it's a virus. So the majority of what we do is supportive care. And what the hope is that we can do things to try to support your body as it's fighting off the infection. And we're looking for anything that we can to benefit within that framework.
Awesome. Let me take you a little back to the start of this pandemic. How did you and your colleagues handle the issue of reusing face masks and N95s when COVID started?
Right. So we were pretty fortunate. There was definitely a limitation of supply. It was not like our colleagues in New York who had to go in very unprotected. However, in my particular situation, you were allowed to sign out an N95, but you had to keep that for about a week unless something happened to it. I ordered something else, a mask that I could wear that also had filtering properties, so that we had more masks for my colleagues. But there were people who, because they got their own PPE, there were people who were fired by some hospital administrators because they didn't want to alarm other staff members. So I think, again, things like that adds to challenges with the situation that was going on. But we had a mask. In fact, we had N95s. We had to be very judicious with them, but we did have N95s. A number of us had also purchased additional filtering devices. Then for face shields, initially there were not face shields. One of the there's an innovation center with Washington University, and some of the medical students came together and so they could eat face in 3D, and so that ended up with more face masks and more supply of face masks, which was great. Our hospital supplied goggles, which was also helpful. And so those are the things that we did. You had to keep up with your own material. And again, for us, in my situation, in my particular hospital, we were very fortunate. In other places, I mean, you remember the pictures of nurses having to wear garbage bags into work. So so I feel for them. I feel for that. And that goes back to the stress that we were talking about before of how do I do my job? I have a calling to do my job. How do I do it in a way that I can do it as safely as possible for myself and also for my family? And I felt that it was just horrific to watch my colleagues in other areas not have access to the tools they needed to do their job in a safe way.
It was very horrific, Dr. Osborn. What is life going to look like post-COVID, knowing that history, of course, isn't an exact template for what the future holds?
Right. Well, I think we've learned a lot. So I think we've learned a lot about preparation. Hopefully, the medical system in general, the medical system tends to be more reactionary than it is preparatory. I'm hoping that this was a way in which we could sort of understand the needs of preparing for these types of things. But we've learned a lot about preparation. We've learned a lot about infrastructure, how to bring together a joint incident command center, both within an HSO, within a hospital system, and within a region. So I think that those things were very beneficial. I think that we are still learning the importance of maintenance of your healthcare workforce, which is all the things that we were talking about before. People thought that this was going to be a sprint, and it was a marathon. So we have to realize that we have to take care of our workforce so our workforce can continue to work to take care of our community. I think that we've learned some lessons there, but we haven't learned them all. And my hope is that institutions will understand that that is a return on investment that is, in the end, mutually beneficial.
Dr. Osborn, any final comments or thoughts?
Yeah, I think first I would also say that what we talked about before, as far as things we've learned, government and private industry working together, the need to have a government centralized incident command center that is working for all the states and not just leaving it up to specific states to find their way through something that nobody had gone through before. I think all of that is also important. Final thoughts. There's a light at the end of the tunnel. There's a light at the end of this tunnel. The vaccine is important and we can all get there. So get your vaccine. Understand that soon we're going to be able to be together in person. You're going to be with your family. And take the time to enjoy the people who are around you and think about the contributions that God's given you and how you're going to apply that, to your life to benefit others.
There's hope. There is light at the end of the tunnel. Dr. Osborn, I want to immensely thank you for coming to Morbidity and Mortality podcast. And I also want to thank your colleagues, the recognized and the unrecognized, the sparks of light all over the country and the world. And I want to end this on an optimistic note, which you have already started. Mm-hmm. Ladies and gentlemen, there is light at the end of the tunnel. Thank you, Dr. Osborn.
Thank you.